I want to review 7 key implementation tips when it comes to implementing the use of rescue TEE during emergencies at your hospital system. The first of which is institutional buy-in. There needs to be data that's accumulated regarding morbidity and mortality to demonstrate the use of rescue TEE in both shock and cardiac arrest states. And then on the local front, identifying a local champion such as a cardiac anesthesiologist or cardiologist that is TEE certified and can help lead a rollout in this area can be immensely helpful as well. They can help train people that want to use it more and more, and also advocate on behalf of hospital administrators when it comes to needing to purchase more equipment. Number 2, there needs to be training or credentialing pathways to make sure that people are trained and certified appropriately to be able to use this safely. This can involve simulations, mock codes, a basic limited use amount, or an advanced perioperative certification as well. Step number 3 is starting to develop protocols and workflow for how it can be used more efficiently. Having trigger criteria such as refractory hypotension or hypoxemia or cardiac arrest. Defining roles when people arrive for a code situation, such as who's going to place the probe, who's going to interpret the images and do the exam. Will someone be performing documentation at that time? And then having clear cognitive aids that you can use in emergencies, as these have been shown to help us in things that we forget in stressful situations to make sure that we still perform things in a systematic order. Number 4 is evaluating your equipment and access to the equipment. You're going for speed here when it comes to rescue TEE, so you want to think hard about where you actually store the TEE machine and the probes. In the operating room core, in the cardiac ICU, in emergency department resus bays, wherever it is, you want them to be quickly available to some of the highest risk patients. You also want to have a system for sterilizing your probes and have a rapid reprocessing. Number 5 is education and culture. You want to start having awareness sessions when you bring to the attention of surgeons, intensivists, ED teams that this is a service that is now available at your hospital and even should be expected in certain emergencies. Having M&M conferences can help highlight the impact of TEE as if it was performed during emergencies for some patients. Number 6 is quality and safety monitoring. In every quality improvement project, you need to have a way of evaluating the success of the intervention. So by logging cases by indication, findings, and clinical impact, you can track over time how influential this service is to improving patient care in the hospital, and also assess for outcome linkage. Did this improve patient survival, diagnostic accuracy, time to intervention as well? Then keep in mind for step 7 that this can be a phased rollout. Remember, you want your highest trained individuals to start doing this first. The cardiac trained anesthesiologists who have the most experience with TEE in the perioperative setting. Then you can expand this to ICU and emergency department settings where select intensivists and emergency physicians can use this if they have the training to do so. Finally, you can roll this system out into the entire hospital. Every time there's ACLS, if you make sure a TEE machine, probe, and a credentialed user show up who's available to use it to help guide post-arrest management, this can be of significant benefit to your patients.